Athetosis and neuronal linkage. Athetosis is not just abnormal movement, it is the visible result of broken communication between neurons and controlling motions. In athetosis, neuronal circuits between the basal ganglia, thalamus, and motor cortex become disrupted. These circuits normally control smooth and purposeful movements. Hi, my name is Dr. Vas, and today we're going to discuss athetosis and neuronal linkage. Basal ganglia, thalamus, motor cortex. These are the regions in which the disruptions causing withering movements. That is the key idea. Disease description: slow involuntary twisting or withering movements. Muscle strength may be preserved. The problem is abnormal motor control. This is the clinical pattern. Hand, fingers, snake-like twisting, face, tongue, speech or swelling issues, posture difficulty, sleep, movement spectrum, chorea, fast, jerky, decline like athetosis, slow, withering, continuous, dystonia, sustained contraction or posture. Chorea athetosis, chorea plus athetosis mixed together. Pathogenesis: birth apraxia, hypoxia, fractures, dyskinetic cerebral palsy, stroke, trauma, tumor may be involved in the development of athetosis. Wilson disease, Huntington disease might be there. These both are genetically derived diseases. That is the pathogenic endpoint. Normal basic motor regulation, motor cortex, striatum, caudate plus putamen, globus pallidus, thalamus motor relay, motor cortex, and then the smooth movement. That is the direct pathway, and that is the indirect pathway through which all the movements by the humans produce or human produce these movements. That is the mechanism: basal ganglia lesion due to hypoxia, Kernicterus, stroke, degenerative diseases, or there might be a drug effect. Protein inhibitory output, thalamic dysregulation, motor cortex activation, unwanted movements, and athetosis. That is the neurophysiology in one line. Neuronal linkage: caudate nucleus, putamen, globus pallidus, subthalamic nucleus, and substantia nigra are the regions of the brain that are involved in the development of athetosis. That is the co-circuit flow: striatum, GPI, GPE, that causes the thalamus, motor cortex, and unstable loop output feedback as involuntary movement. That is the clinical expression. Diagnosis: observe slow continuous withering, check tone, posture, gait, review perinatal history. MRI of brain investigation through MRI of brain, ganglia, thalamic lesions, metabolic test, Wilson, if Wilson disease is there. Liver copper studies should be there, and drug exposure review. Differentiate from chorea, fast jerky movement, dystonia, tremor, and myoclonus sudden jerks. Treatment: there are certain types of management for the athetosis. First of all, treat the underlying causes. Physiotherapy, occupational therapy, speech, follow therapy. Medication include the anticholinergic like baclofen, benzodiazepine, VMAT2 inhibitor, and other steroid agents. Botulinum toxin can be used for focal dystonic component. or severe refractory cases in special care. That is the prognosis, etiology, progression, treatment, and long-term outlook. Several factors: early diagnosis, static, non-progressive, and unfavorable factor, progressive neurodegenerative diseases, basal ganglia injury, dysphagia, respiratory risk. That is the graphical summary of today's discussion. Thanks and regards. Please like and subscribe this channel for further discussion on rare diseases. Thanks.